It is now 12 o'clock, and welcome to Laerdal's Virtual Sun Week. Together with our Nordic colleagues, we have invited to 4 sessions this week, and we are now on day 3, and it's time for the Danish presentation. My name is Jette Jørgensen, and I am the team leader of Laerdal Medical Denmark. Together with me, I have my colleague Hans Henrik Johansen, who is the territory manager in Denmark. And we have our key person of this session, our presenter, Søren Bech, who teaches at UCL, a professional college that, among other studies, offers the nursing education. Søren will give a more detailed presentation of himself in a little while. Søren will do the presentation of TeamSTEPPS in a Danish setting. After the presentation, there will be a question and answer session, and you are of course very welcome to ask your questions, and please use the question and answer button below in the bottom of the screen, and please ask your questions in English so that everyone can understand. After this live webinar, you will receive the slides from the presentation and also the recorded webinar. Before we start, I will just ask you 2 questions. And the first question comes here. One moment. And please give your vote. And we will end in 3 seconds. 3, 2, 1. And as you can see, Norway is leading with 36%. Very good, Norway. And we have, of course, glad to see also good representation from Denmark, Finland, and Sweden. Welcome to you all. And I will just raise another question for you. How many times have you participated in this week's Virtual Sun webinars? Please give your vote. And I will end in 3 seconds. 3, 2, 1. And good to see that many of you has actually joined also on maybe Monday or Tuesday. So happy to see that you are still going strong, many of you. And remember that we also have our last webinar tomorrow from Sweden. So now we are ready, and I will give the floor to Søren, and I hope you all enjoy this session. Here you go, Søren.
So here we go. So welcome to this webinar, which I've called TeamSTEPPS in a Danish setting. My name is Søren Bech, and I'll just say a little about my background and the work our team in UCL Nursing Education in Svendborg are participating in. I've been teaching nursing at the University College for the last 20 years. There's been a shift from mainly psychiatry towards emergency care and critical care for about 7 years ago. And at that time, my skills in emergency nursing was, let's say, very limited. So I had to improve them. So for the last 5 years, I've spent 3 evenings a week in the emergency department as a spare time job, working as an emergency nurse, where I've been working together with the nurses I've trained and graduated from the nursing school, where now the power in the relationship has changed and they loved it. My experience in simulation is partly from being a member of a team designing simulation spaces at University of Southern Denmark, and from psychiatry, where I've trained communication and relationships with psychiatric patients in a debriefing / feedback setting. So I'm the one who's designing surroundings and the simulation, and I'm the one who's trained in asking stupid questions in a polite manner with the scope of changing mindset and negative automatic thoughts of psychiatric patients. And this actually is a gift when you are working in an emergency department. So let's see where we are from. We are from Svendborg. Nursing education is placed in Svendborg, Odense, and Vejle. And the focus in Svendborg is a little bit different from the other one. The focus is on teaching nursing in an evidence-based practice. We aim at educating brave nurses who can take action in a complex world. And we build on strong relationship with our students, clinical practice, and the community around us. So to sum it up, we educate curious nurses who can take action and are team players. And of course, team players lead us into TeamSTEPPS in a moment. Team training, as we know it in healthcare, is often thought about in a setting like this. The resuscitation room or the trauma room, depending on which patient is in the room. But maybe we have you can call it off-piste view of which context and scenarios actually demands team players. We can all agree on this setting, and we often compare ourselves to high-performing, highly trained team as Formula 1 teams. And thereby, with use of metaphors, we try to transfer knowledge from one area to our area. But perhaps we don't understand what it means to be in a Formula 1 team. So perhaps we can't transfer the knowledge from Formula 1 team to nursing or to healthcare as well. Perhaps we're just happy to see the coolness of being in red working on a Ferrari. Or else we try to picture ourselves as parachuters who make impressive formations with a speed of 200 kilometers per hour towards the ground. But if we don't understand parachuting, we can't transfer the knowledge to our setting. So perhaps we need to look at some other context. Is there a need for a team in this context, or is it just a wife feeding her husband? Sorry. Or this team at the hospital? Do we need a team in this context, or do we need teams outside the door supporting this context? If you look at TeamSTEPPS, hands-on team training is essential to nursing education. If we accept the needs for teams, TeamSTEPPS offers us a framework for team training. And TeamSTEPPS is short for Team Strategies, Tools to Enhance Performance and Patient Safety. So we are working towards patient safety, keeping a performance, using tools and strategies to acquire that. So the agenda for this webinar will be looking at evidence-based practice, looking at how we are integrating simulation into nursing curriculum in our institution, looking at the core frameworks we use for training nurses in our institution and education, looking at the context for simulation, in which context are we training for team or doing team training, and finally looking at TeamSTEPPS and what it's offer in a setting like nursing education. And finally, we will get to Q&A. If you look at evidence-based practice, then research shows that evidence-based practice leads us to higher quality, improved patient outcomes, reduced costs, and greater nurse satisfaction than traditional approaches to care. Even though many nurses remain inconsistent in their implementation of evidence-based care, they see it as a quantitative, non-nursing thing to integrate in their practice. But actually there's an evidence base, there's the patient values, and there's the clinical expertise or competences and experience. And those three have to be combined in an evidence-based practice. And perhaps it's because we have a lack of skills in search strategies and grading evidence, choosing evidence, and implement it into our practice. So if we continue having those misunderstandings or misconceptions about evidence-based practice, we have a difficult time ahead of us because we are limited on resources, we are limited on staff as a resource as well. But we are in a situation right now where we need to do the best we can to get our patients well and stable, of course, seen from an emergency perspective. This is the curriculum from our 5th semester, where critical care and emergency nursing are at the focus, aside with clinical decision-making and clinical leadership. It's a 20-week long semester. The first 5 weeks, we train evidence-based practice by conducting a critical appraised topic or a CAT. The clinical practice asks clinical questions who our students work with for those 5 weeks. They formulate a PICO question, search literature, checklist articles, grade the evidence, summarize their findings, and present them in a scientific article written in English. They do a podcast, they do a poster, and they do a website to show off their work. After the critical appraised topic, we have 6 periods of 14 days where palliative care, triage, respiration, cardiology, abdominal pain, and gastroenterology, liver cirrhosis is in focus. Each period of 14 days starts with multiple choice questions, pre-test, where the student conduct 40 to 70 questions. And often the results are low, let's say that. Then we have a case taken from a clinical setting, lab values, X-rays, ECGs, lab answers. And then we have clinical staff from the clinical practice teaching the students, working through the case with them, as well as educators from the school teaching different topics during the 14 days. We do skill training in our care lab, IV access, oxygen, Foley catheters, and different other things. The work with the case, the work with skill training, the work with multiple choice question ends in a simulation, and the simulation is high fidelity. We just bought 4 nursing and mannequins, nursing and simulators. So we have 4 simulators, 2 mannequins, and 2 dolls for resuscitation, the nursing and QCPR. After simulation, there's a measurement of clinical leadership and evaluation of the period. And as you might notice, we have a focus on diagnosis, which we are shifting to symptoms and domains instead of diagnosis. So we are shifting towards a more nursing context than a medical physician context. Each student during the semester urged to create a bucket list for learning. So every time they stops and find out they need more learning or more competences or more skills, they are they are urged to write this in a bucket list. So they have lots of small pieces of paper in their pockets, create a list and check them off. So what they do is they collect learning opportunities. The list makes the students responsible for getting learning done. The list can be shared. We as faculty can ask questions to the list, and the list makes it possible to engage in relationships with students about their learning. So focus is learning in a relationship and thereby in teams. So a lot of this design of the curriculum are focusing on team collaboration and team training. For having an evidence-based ground, we have chosen 4 frameworks that we work with. The fundamentals of care, which is a conceptual framework for nursing. Sorry, the situated clinical decision-making framework from Gillespie and her team, the National Health Service Clinical Leadership Framework from NHS in UK, and then the TeamSTEPPS model, who is the focus of today. And these 4 frameworks are grounded in a didactic inspired by the Harvard Medical School's case-based collaborative learning, where we work with cases, we work collaborative in groups or teams, and do simulation as a knowledge sharing. So they have to share their knowledge through simulations and through taking action and through being brave students or nurses. The Fundamentals of Care framework outlines 3 core dimensions for delivery high quality fundamentals of care. A trusting relationship between the patient and the nurse is the center or the core of the framework. Integrating and meeting a person's physical, psychosocial, and relational needs is the next circle. And at last, the context of care is supportive relationship development and care integration. So the care will shift in different contexts. The framework outlines what is involved in delivery safe, effective, and high quality fundamental care, and what this care should look like in any healthcare setting for any care recipient. It emphasizes the importance of nurses and other healthcare professionals developing trusting therapeutic relationship with care recipients and their families. So here we have a focus on the patient and the family. And with the other models, we have a focus on being in a team delivering fundamentals of care. I just have to look at the time. I think we are on time. Nurses' clinical decision-making is a complex process that holds potential to influence the quality of care provided, and patient outcomes are often challenged by the clinical decision-making we are doing in the clinical practice. We have lots of well-documented research saying that experience is a good thing to have, but when we send out young nurses who don't have any clinical experience, we have to have a framework for making clinical decisions so that they can do effective and safe nursing towards the patient. But we have had little attention on how we do train clinical decision making. So this model is made by Gillespie and Tanner in 2010. It's quite an old model in US, but in Scandinavia, I think it's quite young. We look at signs or cues or symptoms from patients. We make a judgment and we make a decision and an intervention, a nursing intervention, and we make an evaluation of the intervention. The ground of the it may look like a house, but the ground of the house is the person, and the person's is different from the patient. So the patient have blood pressure, vital signs, perhaps a diagnosis, symptoms, and the person has a lifelong experience being that person. The other side of the house is our evidence-based knowledge, and up here we have my competences and me knowing myself and what I can and what I cannot do in a clinical set. And the other part of the roof is knowing the profession. And the house or the clinical decision making is placed in a context, a micro context, a meso context, or macro context. And the micro team or micro shift is focusing on me and the patient and a physician, lab worker, and radiologist. And we are team together, working together with the patient and the patient's family on the clinical decision making. Those clinical decisions need to be put in a clinical leadership. And often people understand leadership in many different ways, but perhaps the most common is a strong leader, powerful, charismatic, who has followers with clearly subordinate roles. But they do exist somewhere and in some settings, but they are quite limited and rather outdated. If you look at leadership in a more modern conceptualization, where you see leadership as something to be used by all, but at different levels. So this model of leadership is also often described as shared or distributed leadership, and is especially appropriate where tasks are more complex and highly interdependent, as in healthcare. So this model is developed in the UK in 2010, 11, 12, 13. There are some adjustments in 13, 11, 12, and 13. So every nurse takes part in the leadership in demonstrating personal qualities, being aware of my own values, reflecting of my attitudes and actions, how they relate to other persons in the setting. I have to work with others in an effective way. So I have to demonstrate effectiveness in developing networks, building and maintaining relationships, encouraging contribution from other co-workers, and working within teams. In this, and of course, this is described in details in the model. I have to manage the service. I have to manage the flow for this patient. I have to manage the flow for the emergency department. I have to manage the flow so we are not crowding the emergency department or the bedside ward or the home care. And I have to have a creative look at my practice, so I can use innovative methods to improve the service, to improve the healthcare, to improve the safety for the patient. And in the leadership of the single flow for the single patient, I have to set a direction, setting a direction towards home care, towards inward, towards cardiology, towards surgery. So I have to be aware of those 5 domains of clinical leadership. And the two, one of my male students described those two. They are the actual leader, the one who's getting paid for lead. He described it as the breaks outside the clinical leadership. Perhaps it's right, perhaps it's wrong. We may look into research about that. So we use those 3 models: fundamentals of care, situated clinical framework for clinical decision making, and clinical leadership from NHS framework. And then we train simulation in 3 contexts. The home care situation in Denmark, we have emergency response teams in home care. So there's 2 good-looking nurses go out to home care, evaluate the patient, and perhaps start treatment at home, perhaps admit them to emergency department. If they, in our simulations, they admit them to emergency departments. So at the emergency department, we triage the patient, we resuscitate the patient, we make the patient stable and diagnostic the patient, and sends the patient either home to the emergency team or to the ward at the hospital. The length of the simulations is about 15 minutes, and then we break up and do debriefing, and we have a complete session of 3 hours with 15 students and 3 members of the faculty. So we are quite close to the students, we are quite close to the context, we are quite close to clinical practice, I think. And in the situation or in the simulation, we use TeamSTEPPS. Finally, we are here. TeamSTEPPS is a framework with tools who are enhancing the performance and patient safety. It's an evidence-based program aimed at optimizing performance. If you have used the SBAR, you have used one of the tools in TeamSTEPPS. The model depicts as a team structure we are working on obtaining, and there's 4 skills that can be learned. So you can learn leadership, you can learn situation monitoring, you can learn mutual support, and you can learn communication. And by learning those 4 competences or skills, we will get attitudes of mutual trust and team orientation. We will get performance where the team can adapt to different situations, can work with accuracy, can be productive, can be effective, and can be safe for the patient. And by that we gain knowledge of the situation and the patient and obtain a shared mental model for what is going on in this situation. So training for this has been shared from the developers of TeamSTEPPS, which is partly the American military and their quality department. So they have developed 113 scenarios training TeamSTEPPS. So I can look at the tool from TeamSTEPPS SBAR, for example, and then I can find the scenarios in different contexts, different settings. So I can choose the love of my life, emergency department, and then I can see if I want to train specific tools. Those 4 scenarios will help me do that. So everything is designed, implementation is designed, core teaching methods is designed to implement TeamSTEPPS. And by that, we can look at how to create effective team leaders. An effective team leader will be able to organize the team, identify and articulate clear goals. What are we looking at for the patient? What are we making interventions for right now? Is it a breathing problem? Is it a disability problem or circulatory problem? The team leader can review the team's performance. They can facilitate information sharing. They can manage and allocate resources. So when we started with simulation, some patients didn't get an IV access because the one student who stood with the IV access couldn't obtain access to the veins. Now we have to train a team leader to allocate resources so that another person can gain access to the patient's vein and we can do a resuscitation. Communication is a great, a big part of team training, where we try to obtain with these 4 tools, try to obtain a structured process by which information is clearly and accurately exchanged among the team members or the students. So they train ESPA, they train call out or closed loop, like check back, they train handoff. We have a different handoff in Denmark, but the benefit of I pass the baton is it's evidence-based. So perhaps we are shifting towards I pass instead. We train situation monitoring, where we have an acronym for the STEP. Situation monitoring is a process of scanning and assessing the situation, gain and maintain an understanding on what is going around and what is going on around me. In the awareness, I know what's going on, and I have a shared mental model with my partners or with my team members. So we all know we are working on patient's breathing problem, we are working on this circulation problem as well, and we are at the same page in this situation. Often we saw nursing students climbing the walls in different directions. Now we have a team and a focus for the patient, which is more safe for the person and gets higher patient safety. And of course, you have to maintain the situation awareness and ensure that all team members are on the same page, but that's the team leader who's responsible for that. And then we look at the members of the team from the acronym I'm safe. Do you have taken any medication, pain medication because you're sore back? Are you stressed right now? Did you do alcohol or drugs? I don't think anyone says that the night before. Is there fatigue in the team? Have everyone been eating? Have everyone been eliminating this day? So safety of the team is as well an issue or a focus. And then we train mutual support, and this is really challenging in a young generation as the millennial generation, who is described in research as me, myself, and I. We train task assistants. We make things goes wrong, so they need to ask for assistance. We evaluate feedback. We assess, use assertive statement. And by training this, we right now we think we get more supportive students. We think they are supportive to each other more than before, but we don't have research yet. But we are looking into research in this area especially. And then you do team events, and perhaps I will shift to this one instead. Team events are a brief before the patient arrives. It's a huddle where you stop and get on the same page, and it's a debriefing afterwards, the resuscitation period. And we see this in CPR training at the first semester, where we do compressions for 1.5 hours in total, I think, with 3 students, or 4 like here. So the skill training focuses on CPR and ventilation and using AED. They all think that they can do CPR. They all have trained, when they get a driver license in Denmark, they have trained CPR. So at the start, there's no problem. And my point is, please make a team of 3 or 4 around the phantom. Get the phantom to survive during 10 minutes of compression. And then we use the QCPR app from Laerdal to show the results. And we often get low percentages, about 30 to 40% of survival. And of course, this is bad, but they They think they can. Of course, they have to train. Then they do, after 10 minutes of compression, they do 10 minutes with compression and feedback from the QCPR app. They get feedback from the app saying reduce breaks, deeper compression, lower speed, and so on. And feedback is, of course, also the students' own observations, who they train in the huddle, like they're doing in the two pictures. And then they can do CPR again for 10 minutes. So now we are 30 minutes. So we are trained, one without feedback, one with feedback, and one more with feedback. We do one round of 10 minutes more with feedback, compression, and ventilation in a 32 manner. They still get feedback from the app. Then we do 10 minutes with CPR ventilation and an AED. Then we do 10 minutes with CPR ventilation, AED, and no feedback. Then we do CPR ventilation again with feedback, and finally we do the race. And they have sore arms next 2 days. But the bodily embeddings of CPR is they get results from 98 to 99% of CPR with compression and ventilation. And we have to maintain this skill by training again and again during the education and after they graduated from school. The brief checklist is used before all simulations. Who's on the team? Do all members understand and agree upon goals? Are roles and responsibilities understood? What is our plan? The team leader makes a plan with the team. And what is staff and riders available throughout the shift? Do we have other teams coming into this team working as a so we have to make 2 teams work together. How's the workload? And what resources are available? And we have, for the last 2 years, we have asked the students to get all the equipment they need to resuscitate or evaluate this patient, bring it in from the simulation room or the care lab. So they have to collect all things by themselves, and by that they learn to evaluate this situation demands this kind of resources, this kind of equipment, this kind of medication. And we are quite happy to do that at the moment, and we hope to publish research that it will have an effect on patient safety and their understanding of nursing care. Afterwards, we used a debrief checklist from the TeamSTEPPS. Was the communication clear? The communication is never clear, I can tell you. Were roles and responsibilities understood? Was the situation awareness maintained? And so on. And the perfect thing about the TeamSTEPPS is that they have research showing where is the barriers. So when we have a debrief checklist and we have issues, what went wrong, what went well, what can be improved. We have a list of barriers in the red here, and the perfect thing by TeamShift is that all these barriers can be solved by using these tools and strategies. So if we train tools and strategies, communication, leading teams, situation monitoring, mutual support, we will have better outcomes. We will have shared mental model, adaptability by the team orientation, neutral trust, and so on. And most important, we will have patient safety. And so we look into our future work right now. We do research, and more research on simulation. We have to prove that simulation is can be designed to improve nursing students' competences and clinical skills, and make a more engaging and softer and less issue when becoming a new nurse in the clinical ward. We're looking into designing scenarios. Looking at 131 scenarios is quite a bit, and we're trying to take the 6 scenarios and making sub-stories in these scenarios by using a scripting tool for writing movies and theater plays. So we can turn off clinical leadership, we can turn on communication, we can turn off clinical skills, we can turn on clinical skills by using that tool, and we can get different output in PDFs from what does this scenario look like, what do we have to train. And in 22 we are looking, we bought an XR lab with virtual reality, and will train virtual reality and scenarios from clinical settings with our students. We have done a little bit by creating virtual reality scenarios with a 360-degree camera and showing it to the students so they can wear glasses or a Google Cardboard with their phone. And the final, you are all invited to collaborate with us. So please connect with us. And thank you for your attention. Do we have any questions?
Yes, thank you, Søren, for this nice presentation. Now I'm not able to start the camera for some reason. I don't know why. But I've been on camera in the beginning, so I don't need to go on camera again. But I can ask, one of the questions, Søren, is in which semesters do you use simulation in the nursing program?
All semesters. We use simulation in first, second semester. We use it in third semester, where we are third semester. We use family nursing as a framework for nursing, and look at patients with diabetes, dementia, and psychiatric patient. And we are developing simulation for all scenarios, for all contexts, with the new nursing and the simulators we bought. We see it as we got 4 new colleagues.
Yes. Next question, can you elaborate on your pre-test? How does the students cope with a pre-test?
The pre-test is, we have to get the students' mindset on the topic of the next 14 days. So they have to shift their mindset towards palliative care. They have to shift their mindset towards cardiology or acute chest pain. They have to shift their mindset towards liver cirrhosis. So we ask questions. What is the ABC? What is liver cirrhosis? And they have a 4 or 6. They can choose 4 or 6 answers. Sometimes they can choose up to 12, and the 7 or 8 is right. I think it's 7 when we ask for patient safety. And if they get all 7 right, they get 1 point out of those 70 points. And they are sometimes furious because they did something right. But in patient safety, you have to get most right. So that's why we give only 1 point for everything has to be right. We ask questions for nursing, anatomy and physiology, medication, pathophysiology, and sociology, ethics. So they get a broad range of questions.
Okay.
And the focus is starting their minds towards the topic of the goal for this week.
Yeah. And there's another question here. Have you translated the TeamSTEPPS pocket guide into Danish?
Nope.
No.
That's the short answer. I don't think we are going to. the student, we have just worked with a critical appraised topic. They have written scientific articles in English. They have graded the articles. They have been using checklists. They have published an English paper by themselves on our website. So translating it to Danish will be saying that all that work was only for using time or just spending their time. So I think we keep it in English. But okay. Perhaps if we use it in a clinical context, we have to translate it.
Yep. And there's another question here, maybe it's more or less the same, but is there an equivalent to TeamSTEPPS in Danish, which is newer than the handbook from 2009 from Sikker Patient?
I don't know. I think Sikker Patient is the latest.
Okay. And another question, is it possible to share your reference to the TeamSTEPPS you use?
Yeah, sure.
Maybe I guess, yeah, I guess what we will share your presentation afterwards, so we can put maybe references in the slide presentation. So we'll, and also there was another question about the references for the figures you are using in your presentation, that if they want to search for it or use it, then
they will be there as well.
Yeah, good. And there's another one here. I do a research project with implementing TeamSTEPPS in a Norwegian Bachelor of Nursing Education and would like to keep in contact. I have done a TeamSTEPPS intervention in 5 semesters towards one group of nursing students. So that's for sure, we will keep in contact here. And in this power slide, you will also have your contact details, I guess, Søren, so people can reach out to you afterwards.
Yeah, sure.
Okay, let me just see if there's more. Yes, there's another one here. Can you elaborate on strategies and tools you use to ensure team competences long term? For example, do students simply complete a simulation a year later with an assessment, or are there collaborative tools to give feedback to each other?
There are collaborative tools to give feedback to each other. There are worksheets and the website of TeamSTEPPS. So you can keep on training, but our 5th semester is the last semester in nursing school where you train TeamSTEPPS. The next step is a clinical setting in 6th semester, and the 7th semester is a bachelor thesis.
Okay. And then a question here, did I get it right? Do the students get a multiple choice questionnaire before each 14-day clinical practice period?
Yes, indeed. And that's just for turning on their brain and reflections. We note that neurons have to be trained a lot before they change in a new direction.
Okay. I can't see any more questions right now. I can ask a question, Søren. Do you repeat the scenarios or the TeamSTEPPS? I mean, if you have gone through a scenario or TeamSTEPPS, you evaluate, and there's maybe, I guess, always something to improve. Do they get a second, a third chance?
Yeah, they do. In the same setting, or they can make an appointment in our care lab with a clinical nurse or one of our faculty members. We have a nurse responsible for the care lab, and they can make an arrangement with her and train the scenario once again. Or we can make an appointment with one of the teachers or and train it again. And we are looking into translating the new scenarios we write with the scripting tool. We are looking at translating them into the SimPad, so you can be self-pacing in those small scenarios from TeamSTEPPS. And if we do that, we will of course share it either on our own webpage or somewhere else.
Okay. Thank you, Søren. So I can't see any new question has been raised so far. So,
I have one, Jette.
Yes, værsgo Hans Henrik.
Yeah, I just wondered, Søren, you're both educator for the students and you work with them as well, right?
Mm-hmm.
So what are the benefits from that and what are the non-benefits from that?
The benefits is I know what I'm teaching. I did it last evening. This morning I teach depression and myocardial infarction, and I saw one in the evening yesterday. I saw the family's reaction. I saw the patient's reaction, and I know the models, the frameworks I use in teaching, and I can draw on that experience. I can use the clinical experience I have to engage students in work. Often I'd have a student with in the emergency department. Let's go look at some nursing and see why it's important that we do as we do in the nursing school.
Very interesting. And Søren, when I can see that model, but when you work in the clinical setting, what about your colleagues out there? Do they recognize the model that you use as well? Do they see any improved competences from the students?
Yes, I think so. They are working with the clinical decision-making framework. They're working with NHS leadership framework. For example, we have experience when you meet the first nurse in the emergency department, when you have a luxation or fracture of your hip or elbow. It's described as we take an X-ray, we get a diagnostic answer. Either you go home or you will go to have it, let's say, replaced or fixed, an operation if you have a fracture. But when it's described in our clinical guideline as 1 or 6 steps of clinical decision making. But when you look at it, you evaluate A, B, C, D, E, F. You evaluate the patient's respiration, activity level, elimination. You evaluate all about the patient vital signs. So when we counted, it was over 400 clinical decision makings, or 400 and between 400 and 500 signs you have to evaluate it in clinical decision making. Do I do something or is it okay? Do I do something or is it okay? So combined between the physician and the nurse, there was those 400, 500 decision makings in one setting, described as 7 in our clinical guideline. So I think we experience, wow, we have to look into this more than we do.
Very
Okay,
interesting.
there's just 2 other questions has come up. We have about 5 minutes left here. The last question about clinical practice setting in semester 5, is it a semester where the students are on the school?
Yeah, they're on the school. And the 6th semester is the same length, 20 weeks in clinical settings.
And another question here, is the multiple choice form online, and do the students see the same time if the answer is correct, or is it you as the teacher who corrects the assignments?
They are made in Google Analytics, and Google Analytics has a test tool where you can have feedback. So, for example, if you we have a question of how's the brain? What are the anatomy of physiology of the brain in responding to the activity you do? and we have feedback with you from YouTube on that, for example. We have feedback from lab values. If we ask for that, we have feedback from medical databases, or we have feedback from PubMed. If they got a wrong answer, we send them to a research article.
Is it? It's just a question for me, Søren. But is it possible to? Is it that kind of a link or a browser so we can share with the participants afterwards, so they can?
We can try. I have to ask my colleagues if that's okay.
Yeah, just to give an example to see how you.
And we have to check GDPR, because we have pictures who cannot be shared outside the school.
Okay, we will look into that to see if it's possible.
Mm.
Yeah. No more questions in the question and answer box. Hans Henrik, have you more?
No, I would just like to say thank you for an inspiring presentation, Søren.
Thank you for having me.
We are glad to have you, Søren. And the time is almost up now also, so we are on time, Søren. Good that we managed that as well. Very inspiring to hear that presentation, and of course you will share your presentation afterwards, and the recorded webinar will also be shared with all participants. And then just a reminder that tomorrow we have the last webinar. This is Sweden that is presenting tomorrow, and it starts at 12 o'clock as today. So hope to see or meet a lot of you tomorrow as well. So that is the end of the Danish webinar. Have a good day, and looking forward to maybe see you again tomorrow.